My name is Dr. Sandar Hlaing, and I have been a GP since 2008. I've been a doctor since the year 2000. I was trained in Myanmar and then I came to the UK in 2002. I started in London in 2004 and then I finished my GP training in 2008. I do like making people feel better. So when I was younger, I was either a doctor or a teacher in my the games that I play as a child. And with being a doctor, my patients come to me with a problem and they get better. As a teacher, my students come and tell me to explain something, and I explain something, and they felt so much better because they understood. So I like that sort of feeling. And then eventually you do your exams and then you get enough qualifications to get to the medical school. And that is what I like about being a doctor. You can actually explain to the patients as in what, why are they feeling, how they're feeling now, and what we can do about it, and what they want to achieve. So, you can try and match these things, which actually makes somebody's life better. And that's actually very nice to see. So the general practice is my actual specialty, which is family medicine. You look after all ages. I would see the babies from as a newborn to all the way up to the end of life for somebody. And that actually gives you satisfaction. And as a general practitioner, you get all the patients' whole medical history in front of you, and you can actually look at how they were like before, and then you can see like why they're feeling down at the moment, or why they want to be how they used to be. So it is quite a nice profession where you get to know the patient, you get to know the family, and I get to practice different things as well. Because as a general practitioner, I can see the patient, examine the patient, diagnose, explain, etc. And then if they need some procedures, I can do the same time as well, like joint injections, or in cases of women, I could do like implants, coils. And if I see a menopause patient, if they feel like, oh, I'm like my body has changed, I don't like my body structure, I can give them advice. So that's how I eventually learned more and more about different specialties. So I started seeing women more because I was the women doctor in the practice. So I learned a bit more about women's health. I get more diplomas there. I learned more about contraception. And then I saw more women with menopause, and I went through menopause early myself. So I learned a lot more about menopause. And then when you see a woman of certain age, there are certain areas that they're very unhappy about their appearance, and that really get them down. And some people might feel like, well, this is actually very superficial, but that gets a person down. Anything that could help would help. So that's why I started studying aesthetics. So that's how I chose my specialties. And a lot of my patients get older. So I started elderly care medicine more, because when you get older, you don't want to be seeing like five specialists. You want to see an elderly care specialist who could do all the things together. So that's how I chose my specialties as I grow, as my patients grow. And then I learned a bit more about what my patients need. I like to help patients achieve what they feel important to them. And that is what's rewarding for me. So, it depends on my patient. If it is the mother who is interested in how to help their children, I will do that for them. If it is a patient who is feeling down, or feeling like I can't achieve my potential as I used to, that's what I will help with them. So mainly the most rewarding part about my job is to help them achieve what is important to them, and how we can get there. We do that together. I think it's because I listen. I I would leave the first part of my conversation as to I tell the patient that please tell me everything from the beginning. and you just say everything you think is relevant, or even if you think it is not relevant, but you would like me to know, just say everything. And then I will ask you questions as we go along so I can fill in the gaps. So they felt like they've actually been listened to. And then I will ask them like, okay, so I have got an idea, but what is actually important to you? What do you think that you would like to achieve after this consultation, and how we can get it together? So, I go with like, what is the patient's idea? What is their main concern? And what do they actually expect? So they go out of a consultation feeling like they've been listened. They have a plan as to achieve what they want to achieve. I do like my patients to take interest in their well-being. If a patient take in charge of their well-being, their destiny, it's a lot easier for us to achieve that. So I like my patients to tell me everything and then tell me what they think they want, and I can actually tell them, well, this is achievable. This might be pretty hard to achieve, but that could be our long-term goal. And then we do that together, because I do cognitive behavioral therapy as well, because when I started menopause training, I find that not everybody can have hormone treatment. And non-hormonal treatments work for some people, some it won't. And some people with the menopause treatment, even if they are on hormones, that doesn't always achieve the 100% potential. So you need a little bit of extra, and that cognitive behavior therapy works. And that basically works mainly by the patient. I can only tell them how they can interpret their symptoms and how they can actually instruct their brain to change their perception of the symptoms and change their reaction to the symptoms. So that really requires the patient to work with me. So I would really value my patients to work with me.